The Small Rural Hospital Transition Project, or SHRT for short, supports small rural hospitals nationally by providing on-site consultations and education to bridge the gaps between the current healthcare system and the emerging healthcare delivery and payment system. In 2019, Val Verde Regional Medical Center was supported through SHRT with a Quality of Care and Transition of Care project. Val Verde had begun the implementation of their action plan, and then the COVID-19 pandemic began. This quickly forced the hospital to adapt their SHRT project action plan to the pressures of the coronavirus in the face of a surge. They share their story here.
As everyone knows, rural communities are resource limited, and to have the experience of the people behind the SHRT grant come in, do an assessment, advise us where our opportunities were, and then help walk us through those was invaluable.
The SHRT grant allowed us to collaborate with other rural hospitals and understand the importance of population health, and let us hear and experience what others were doing so we didn't have to reinvent the wheel.
Our community experienced COVID in a very profound manner. We were in a lull back in March. Our hospital was virtually empty. We had very few patients. And in July, we were slammed. And when I say slammed, we went from no patients to our hospital was almost full. And we had very little resources. We did not have enough PPE. Our staffing became sick, and so we literally had to send out an SOS for resources to come in and help us. When they arrived, we had a team from the Navy and from the Army, critical care nurses, pharmacy, but most importantly, to help us get through it, we had a critical care pulmonologist. He came into our hospital and taught us how to handle COVID. We were fortunate to have them for 2 months. During that 2 months, we experienced losses in our community. We even experienced losses in our employees. Needless to say, it rocked this community. While we did feel that we were prepared, what we discovered when COVID hit was that we had not really done a dry run on our surge plan. Putting up zipper walls, teaching the donning and doffing. Even though we are a hospital, we rarely have vent days. I can tell you that in the entire year prior to COVID hitting, we had 31 vent days. In 60 days, we had almost 200 vent days. Every one of our ventilators were in use.
It's traumatizing to be in PPE for 12 hours a day, or actually it's more than that. Because they would have to work extra or long, wear that mask, face shield, and goggles all day long, have the bruises and the lesions. I had no idea how traumatic it would be for my staff.
Our community came to our rescue during COVID. What it has done is it's created more of a bond within our hospital because people were working side by side in full PPE for 12-hour shifts. They understand what each other was going through. And then when we lost 2 of our own employees, it really, it brought everyone together. And in a sad way, a lot of tears, but a lot of support. We set up a memorial for each one of them. So when you come in the back door every morning, you see them, and there's a book, and you can write a note, a story, and that memorial is still there today. The community cares very much about this hospital, the care that we give, and the people who work here. And they consider especially the frontliners, the true healthcare heroes of this community.
As a hospital, we took a very active approach communicating with the community through social media. Obviously in a rural community, we don't have TV stations, we have a small newspaper, so we use our Facebook to communicate.
What we learned going into the program was we knew we had a lot of opportunities. We had metrics that we were going to hit through this program, but because of COVID, we didn't actually get to a lot of the things that we wanted to in the program. Even though we were in a pandemic, we learned how to improve our HCAP scores. Our patient satisfaction scores actually did go up.
One of the things a key focus was retention. Unfortunately, that has been a real challenge. COVID scared a lot of employees, and during the past 9 months, we've seen an increase in turnover, but we've seen an increase in recruitment because people have realized the opportunity to work in our organization and make a difference in patient lives. We created a program called Healthcare Heroes, a nomination program based on, who have you seen really going above and beyond, and you identify as a healthcare hero. We also rolled this program out to the community, and we created a whole campaign. And every week we recognize at least 2 healthcare heroes. So we really feel this has engaged not only our employees, but our community. COVID-19 really pushed our telehealth program 10, 15 years ahead of where we thought we would be today. We had been doing telepsych, so that program runs really well. We started doing telehealth, and now we have ventured into telemedicine, where our patients are given a pod, and they can take home a blood pressure cuff, a diabetes, a pulse ox, a scale. There's a variety of tools, and at home they can log in, connect, and their information is sent to us via the internet. And then when they meet with their doctor, the doctor can measure and see their blood pressure, their daily blood pressure, their pulse ox, their blood sugar level, what have you. So that's now our next level of telehealth. We're now exploring telehealth in our ICU and ER. That was something we've been trying to do for 3 or 4 years, and now we're really moving quickly to implement that.
Smart ER is an application that it interfaces with the demographics of our EHR, and so 24 hours after our patients are discharged from the emergency department, they get a phone call, a text, or email asking them how they feel, how their visit went, and if they have any questions about their medications or their plan of care. We are using that tool now to improve our patient experience. So we're giving those patients a call back if they want, but also the department directors doing patient rounding using a very similar tool as the Smart ER. We're also using that tool to look at our turnaround times and our throughput, because prior to COVID, one of our complaints was the long wait in the emergency department.
In regards to the revenue cycle, there was a lack of efficiencies throughout the whole revenue cycle, starting from admissions through business office, HIM, and there wasn't really any reporting or measurable data that was being reported. So we've implemented also on the patient accounting side to be able to measure what our clean rate is. I believe that also was below 60%, and when you're looking at your first pass clean rate, you want to make sure that that's at least above 80%. So our first pass error rate has decreased significantly. I want to say we're running at about between 75% accuracy rate on the claims side of things. And with the new HR system, it allows the management to really get a high level of where we are on a day-to-day with our accounts receivable. We have the automatic dashboards that can identify trends down to the specific collector, to a specific payer, where we can see that the trend increasing in our accounts receivable and really identifying what the issue is early on, so we can tackle that and prevent our accounts receivable from increasing. You can't take the whole elephant. You have to chew on the elephant a little at a time. And having the SHRTs program to really help us zero in on the key items that we need to focus on, made it easier for us to stay on task and to reach the goals.
The consultation truly helped us by helping us focus. We knew already what some of our challenges were. We were addressing them, but we didn't have a coordinated effort. And by bringing in the team to assist us, we were really able to focus, taking us through that full 2-day exercise of identifying our top priorities and then identifying specific goals. Really gave us a jump start. I think we would probably be a year behind if we didn't have that support from the short grant.